Good evening. Thanks for coming. We are incredibly grateful that you took time of all the things that you could do for the Saturday Night at Academy, and you came out to see our presentation. My name is Michael Singer, and we're going to talk to you today about DME in the real world, past, present, and future. All right. With that being said, I'm going to switch the podium to Dr. Kiss, who will talk to you about some of the studies that Dr. Sinu spoke about. He did the original research, so he's going to go and tell you implications for Protocol I and all the stuff, why we make decisions the way we do.
Thank you, Dr. Singer. It's a pleasure to be here, and thank you for coming out. I know you have other options this evening. Michael asked me to talk about our Protocol I analysis and some of the real-world data. Obviously, none of this is done alone or in a vacuum. And so the take-home message over the next couple of slides is in patients with diabetic macular edema, early visual acuity and OCT anatomic response may be predictive of long-term response. The data set that we analyze is a DRCRNet Protocol I. Because Allergan provided the steroid in this particular case, they had access to the raw data, and we analyzed that raw data in a similar fashion to what the DRCRNet investigators were able to do, or the committee. And the objectives were threefold. We wanted to look at visual acuity, anatomic response, and this area under the curve. We're going to be hearing a lot about the area under the curve because a response, whether it's anatomical or visual acuity at one time point, may not be indicative of what's happening over the long term. And this area under the curve may be more predictive of how patients are actually doing on a therapeutic agent. So predicting long-term visual response to anti-VEGF and diabetic macular edema. Looking at the Protocol I data set, we looked at a post-hoc analysis starting at week 12 in the subjects who received anti-VEGF therapy plus or minus laser. We looked at the mean best-corrected visual acuity change from baseline and looking at the 10-letter improvers in those who don't improve. If you look at the DRCRNet protocol population, you can see that about 40% of patients improve less than 5 letters after 3 ranibizumab injections. That's a pretty astonishing number. It means that the patients need to keep coming in, and even if they keep coming in, 40% may not improve even 5 letters. So when you look at those 5-letter improvers, what happens to those 5-letter improvers when you look at 1 year or 2 years out? Well, it turns out that eyes with fewer than 5 letters of vision gain after 3 injections showed limited additional vision gain even after 2 years of injections. So if you think about this as swimming in certain lanes, if you're doing well after 3 injections, you're going to do well or likely to do well with a lot of injections and a lot of follow-up out to the end of this particular study. If you're somewhere in between the 5 to 9 letters, you're going to remain somewhere in between. And if you're not doing so well after those 3 injections, you're not likely to do well. It doesn't mean that every single patient does poorly. What it means is that you're just not likely to do as well. So a minority of eyes with less than 5-letter gain after 3 injections do gain some letters. Some of them gain 10 letters. But that's a minority of those eyes. And remember, these eyes require all this treatment. So who are these eyes? If you have these less than 5-letter gainers now, and you look out to week 52, you can see that if you keep on giving these patients injections every month, then there are subjects or patients who will gain those letters. The challenge that I have, even on the Upper East Side of New York, is to try to get these patients who really haven't responded after 3 injections back into my office. Not for the 52-week, that's a pipe dream, but even for the 40-week or the 30-week follow-up. So 77% of limited early responders failed to show a greater than 10-letter improvement at 52 weeks. Subsequent average vision gain in these patients was less than 1 letter by study end. And so the conclusion of this particular section of the post-hoc analysis is that after 3 anti-VEGF injections with ranibizumab, you have a strong predictor of what may happen at 1 year and at 2 years. If you're a good responder after 3 injections, you're likely to be a good responder at 1 and 2 years. If you're a poor responder, while there's still a chance for you to respond with continued monthly visits and injections, that chance is much, much lower. What about anatomic response? Patients care about vision. We tend to care both about vision and what the OCT looks like. So we did a similar analysis looking at the same data set and looking at central retinal thickness response out to 3 years after the initial response to ranibizumab. So if you look at the response to ranibizumab, you can actually split the patients up into 2 cohorts after 3 injections or 12 weeks. You can split the patients up into those that had less than 20% response and those subjects who had greater than 20% response. 35% had that less than 20% response after 3 monthly injections. Eyes with less than 20% reduction at week 12 were significantly less likely to have greater than 20% reduction over the study duration, 156 weeks. Here are those eyes that didn't have that initial anatomic response. While some of them did go on to get that anatomic response, very few went on to actually get the greater than 20%. This is the opposite of if you do have that good response. So this seems to mirror some of the findings of the visual acuity. Now, eyes categorized by early central retinal thickness response differed in some ways from those that did not. Mainly the mean baseline central retinal thickness and prior diabetic macular edema treatment were different. If you had a thicker retina to begin with, or if you had a lot of treatment prior to entering the study, you were less likely to have that response. Even controlling for those 2 confounding variables between the study populations, there's still a difference. A significant association remained between the early response in OCT and the subsequent response out to 3 years. And this is really what it looks like graphically. You can see that these graphs are very similar to what I showed you with the visual acuity. The OCT response tends to swim in the same lane. The early response is predictive of intermediate and long-term response, even in these patients that come back in, even in these subjects or patients that are treated. So what is the conclusion of this part of our analysis? Well, the post-hoc analysis after 3 anti-VEGF injections of the central retinal thickness was significantly associated with long-term central retinal thickness in an unadjusted and adjusted analysis. Limited response early meant that you had limited response in the intermediate and long-term stage, similar to what was seen in the visual acuity. Now I want to introduce you or perhaps remind you of this concept of area under the curve, right? And look at that in terms of duration of edema and the average visual acuity improvement. The same data set was included, the Protocol I data set, and we looked at patients with an observed central retinal thickness at baseline and at least 1 more at any follow-up visit. 367 patients from the Protocol I were included in this part of the analysis. And so what we did was we stratified patients into 1 of 4 groups. If you look here at the number of visits where there was excess edema in the first year, you get really 4 groups. Those that had 0 to 3 visits with excess edema, those that had 4 to 7, 8 to 11, and then 12 to 14. And we're going to focus on these that have 12 to 14. So it means throughout the first year, at every single visit, despite having anti-VEGF therapy, you continue to have macular edema in the first year. And then we looked at the best corrected visual acuity response by averaging the change in the best corrected visual acuity response measured as the area under the curve, right? Now, why area under the curve? Well, area under the curve provides a more complete assessment of patient benefit during multiple time points. At week 12, this patient here, patient A, has the same outcome as patient B. But if you look, patient B has clearly a greater treatment benefit than patient A. This is a similar analysis that's being used by the DRCR-NET and other clinical trials, most recently in Protocol S, anti-VEGF versus PRP for the treatment of proliferative diabetic retinopathy. So what about duration of edema and post-treatment initiation? 1/3 of study eyes showed persistent edema over the first year, meaning that between 12 and 14 visits in the first year, 1/3 of subjects or patients in the protocol eye had excess edema. Basically, at every single visit, there was swelling. Now, protocol eye did not require the investigator to treat if there was swelling there. It was up to the investigator's discretion after the first 6 months. If you look at those eyes, so among eyes with persistent edema at week 52, edema persisted in the second year. So if you did not have edema at week 52, then you did not have edema in the second year. If you did have edema, that's the third of the eyes, then you tended to have edema throughout year 2. Once again, this persistence of the findings in the first year carried over to the second and then subsequently in the third year. Now, edema is okay and the OCT is okay, but what do our patients care about? They care about visual acuity. And so when we look at the average visual acuity improvement over the study duration, what we find is in those subjects who were in this fourth quartile, meaning they had persistent excess edema during the first year in all of their visits, did not gain as many lines of vision or letters of vision as those that did not have edema. 6 letters versus 10 letters. Now, clinically relevant baseline differences were seen in patients with persistent edema after year 1. Similar to what I showed earlier, the mean baseline central retinal thickness and prior treatment attributed to you continuing to have diabetic macular edema even in a study setting. When you control for those potential confounders, eyes with the most persistent edema were estimated still to gain fewer letters compared to those that did not have the persistent edema. Adjusting for those confounders, eyes with the most persistent edema were also significantly less likely to gain 10 letters or more. 10 letters because that's significant in terms of those whopping 10 and 15 letter gainers that we're used to seeing in some patients who are treated with anti-VEGF. And so what are the conclusions? Well, in this part of the analysis, 1/3 of patients experienced persistent edema during the first 52 weeks after initiation of ranibizumab therapy. Patients with the greatest duration of edema in the first 52 weeks post-treatment were estimated to have a significantly lower average best-corrected visual acuity over the 3 years in adjusted and unadjusted analysis. Best-corrected visual acuity improvement, as measured by that area under the curve, accounts for this month-to-month variation that we see not only in clinical trials, but also in our real-life practice. And so I think you're going to be seeing more and more of this area under the curve. What is the benefit, not at one arbitrary time point of 52 weeks, but over the duration of treatment? So in this analysis, we provide new evidence demonstrating the association of functional anatomic response. You can make a pretty good prediction, actually after 1 injection, better after 2, even better after 3 injections. Protocol eye retreatment criteria, as I mentioned earlier, allowed for persistent edema to be observed if no further anatomic or functional response was seen with ranibizumab and or laser. In eyes with persistent edema, early consideration of additional disease management strategies may be appropriate to maximize potential vision benefit. And I think that's up for discussion for the panel and for us all as to what that might be. Is it switching to another anti-VEGF? Is it looking at another mechanism? Is it adding or is it really switching? And so the take-home message is the same. You're going to start swimming in that lane once you start being treated, and you know pretty much what lane you're going to swim in after about 3 injections. Having a recent conversation with the DRCR net, they pick a number around 4, 5, actually 6, most of the leadership. Whether you pick 3 or 6, it's almost arbitrary, right? After 6, you're much more confident. Now, that additional confidence that comes after 3 or after 6 is just really dependent on your level of comfort and actually the patient's level. because those patients who are not getting the response that they want, especially in terms of visual acuity, may not last those 6 injections. And so that brings us sort of to the second part of our talk, which is the real world. So it's great to see these clinical trials where patients come in every 4 weeks, because you have to remember that when you think about monthly injections, there are only 12 months, but many of these clinical trials have injections every 4 weeks, which means 13 visits in 1 year. Now, even on the Upper East Side, people don't like to spend an hour and a half or 2 with me. You know, they've got better things to do, especially our diabetic patients. So what we sought to do was to look at clinical monitoring, utilization, and visual outcome in patients with diabetic macular edema. When we first presented this data several years back, frankly, people did not believe us. This has been replicated several times since. The take-home message is that the visit schedule, the utilization, and the visual acuity outcomes simply do not mirror those that are seen in the real world. For those of you who were at the earlier presentation of Protocol U, which we'll talk about later, to me the most amazing thing was in those patients who had persistent edema in the real world were then put into the clinical trial setting where you had to get 3 ranibizumab injections. A third of those patients were disqualified from the trial because they responded. So it wasn't necessarily that they were non-responders. It's just that people cannot come in every 4 weeks to be seen by you and to be treated by you. And that's really the take-home message of this real-world outcome, looking at a large integrated U.S. health system. We looked at an integrated U.S. health system where the insurance is not an issue. You're in an integrated system where you have access to doctors, and the doctor's choice of medications actually is not an issue at all. Because if you have this particular health insurance and you're in this system, you get treated by essentially whatever the doctor wants to be treated with. So claims and registry analyses suggest that anti-VEGF injections are less frequent than randomized clinical trials. We looked at this integrated health system because we were able to get vision through an electronic medical record. This was pre-IRIS. Actually, the idea of IRIS wasn't even on the table when we did this analysis. IRIS is giving us something very similar. So retrospective analysis, we looked at diabetic macular edema eyes, the usual inclusion and exclusion criteria. We wanted to make sure that you were seen within the healthcare system and you had diabetic macular edema and you were seen at some frequency that gave us some sense of what may be going on. And in the end, in this particular analysis, we ended up with 94 eyes with a baseline visual acuity between 2040 and 2320. That baseline visual acuity was chosen to mirror that which was done in the clinical trial setting. And so the characteristics of these patients of the 94 eyes are what you would sort of imagine it to be in a clinical trial setting. All eyes had at least one follow-up ophthalmology visit during the 12 months following the index period, and 54 of the eyes had consistent ophthalmology visits. So what do I mean by that? Month 3, 6, 9, and 12 windows, at least quarterly. Because your diabetic patient may come in, you may see them, and then you may see them a year later, even though they had macular edema that you may want to treat in between. And so when you look at the average number of anti-VEGF injections, the mean number of injections is 2.6, right? And that this doesn't, in this particular data set, did not change with concurrent use of other medications. So most patients, 40% got 1 injection. You can see that 2/3 got fewer than 3 injections. And I think it's interesting to keep that in mind, at least in this analysis, which is becoming a little dated, because if you look at Protocol U data, those patients received a minimum of 3 coming in and then required another 3. So are they the same patients that we're treating in the real world setting? I'm not sure. You look at all study eyes. I put the RISE and the RIDE data up here. So RISE and RIDE, amazing, 10-letter gain, anti-VEGF, 12 injections, right? Here, when you have in the real world, you know, you're basically flat. You're basically not gaining any vision, you know, 3 or 4 letters. If you look at the mean change in baseline visual acuity here, depending on observed and last observation carried forward, which analysis you use, you're not getting those whopping 10, 11 letter gains. What about if you were seen at least quarterly? So not just in the beginning or the end of those 12-month periods, but at 3, 6, and 9 months. Well, you do a little bit better, right? But still, you know, a 3-letter gain does not compare to those 11-letter gains. Why is this important? Because when you have Mrs. Jones in front of you and you tell her that, you know, you're going to treat her intensively, you're going to cure or make her diabetic macular edema better, and what does that mean in terms of vision? Well, on average, 2 lines gained. Yes, that's what the clinical trials tell us. But in order to achieve that, she has to commit and you have to commit to a regular follow-up schedule and a regular injection schedule. When you look at the response at month 12 in all study eyes, you can see here that actually a non-insignificant number of these subjects, of these patients that were analyzed, lost 3 lines or more. And the gain of 2 lines, well, it's about a quarter, and it's better than what we used to do with laser. It does not mirror that of the clinical trial setting. These are actually just repeat slides. Now, we did an analysis, and we're doing further analysis. There's a remarkable association between the number of anti-VEGF injections and the number of letters gained. You know, my wife, who's an oncologist, and the panel knows this, you know, does not believe how much voodoo we do, right? So if there's a clinical trial that comes out that says you need 6 cycles of chemotherapy for colon cancer, my wife does not do treat and extend 6 cycles. She does not do 5 cycles because that's what she feels like doing. She does not do PRN cycles, right? She does 6 cycles, and so does everybody else. And that's true in New York, it's true in California, it's true in Wisconsin. If you look at what we do, we basically think we're doing what's right for the patient, and I believe that, but most of what we do is not evidence-based. And in fact, we may be shortchanging our patients by not giving them as much anti-VEGF therapy as we probably should, because it's impossible. All right, that's why sustained delivery and steroids come into play. It's impossible for a 46-year-old executive on Wall Street who has diabetes, who has diabetic macular edema, to spend an hour and a half in my office every 4 weeks. Not going to happen. But if it does happen, you can see here with both AMD and DME, the number of injections in all these trials from various sources really goes up with the number of letters gained. And it's interesting to note what you would want to do for your eye if you were in this situation. So the summary of the results, as I've been emphasizing, we're not treating our patients like we think we are or like they were treated in the clinical trials that show these amazing results. And by not treating them as the clinical trials were treating them, we may not be getting the results that we think we are. We may be shortchanging them. Well, what about dexamethasone? How are we using dexamethasone? And these slides are courtesy of Dr. Singer here. But you know, there's some real-world data that I showed you with anti-VEGF therapy. What about real-world data in dexamethasone? And this is another claims database from 2011 to 2014. So when you look at the pivotal trials, dexamethasone in the pivotal trials, at least the initial ones, were given no more frequently than every 6 months. In the real world, we think probably about every 4 or 5 months is the length of the dexamethasone implant life. And so the goal of this was to look at Source LX claims database. It's an open claims data set with data extracted from physician claims. All these claims databases have their pluses and minuses, and that caveat should go in interpreting all of this data, including the data that we had analyzed. But what was done here is standard DME treatments were evaluated, including the Ozurdex implant, anti-VEGF, alternative steroid, including triamcinolone, and of course laser. Laser may not be completely dead. Just like our claims database analysis, you've got the index case, you've got a look back period and a look forward period. You want to make sure that the people you include in your analysis are not a one-off. And so what are the results? Well, the baseline characteristics here look very similar to the clinical trial baseline characteristics. 139 patients had a diagnosis of diabetic macular edema alone. 193 patients met the inclusion criteria, but some of them had an RVO diagnosis as well. And we're looking at the DME only. So when you look at the mean annual DEX treatment frequency in the first year, you see that the mean is less than 2. And most of the patients here received one DEX in that 1 year. Now, most of the patients did not receive DEX monotherapy, but what you can see is that the mean was 1.8, the medium of 1 in those eyes that had DME and maybe something else. And then DME-only eyes, 120, mean of 1, a medium of 1, and the mean of 1.69. And so when you look at the eyes with multiple injections, the mean and medium intervals between all DEX is approximately 4 to 5 months. You know, the companies give us an approval, and then once the approval is there, we start using the drug in the real world. And this is really what my impression is of the dexamethasone sort of lifespan. You can see the individual injection intervals here in the DME eyes and the DME-only eyes. And other therapies, well, other therapies were used here because oftentimes we're combining steroid with laser with anti-VEGF therapy. When we think about the protocol I analysis and when we did that, we didn't think that you would completely abandon anti-VEGF. We think maybe you would consider other things like a steroid add-on or perhaps even more laser. Now, when you think about this analysis, 63% of eyes were pre-treated with something else. 46% of eyes received no other therapies after the index DEX injection. When you look at the breakdown of other DME therapies in all eyes before and after DEX, you look at anti-VEGF, laser, and then other steroids. Anti-VEGF and laser were the most common in this real-world analysis. Other steroids occurred less frequently, but were not unheard of. When you look at the use of other therapies in pre-treated eyes before and after DEX, what you see is that 66% of eyes were pre-treated. About 70% of pre-treated eyes continued to receive other therapies after getting Ozurdex, and about 30% of pre-treated eyes discontinued other therapies after getting the Ozurdex. Now, what is the breakdown of the pre-treated eyes? Very similar. You get the anti-VEGF, you've got the laser, and then you've got other steroids. One thing to note is that the number of anti-VEGF treatments after the dexamethasone is given is significantly less than what is done before the steroid is given. And so when you think about what do we do in the real world, we try to incorporate these clinical trials that use monotherapy, and we incorporate them in order to maximize the visual acuity, in order to treat the OCT, because many of us treat the OCT, but also to decrease that treatment burden. And here you can see that there's an apparent decrease in that treatment burden with the anti-VEGF therapy. Here, use of other therapies in non-pretreated eyes after the DEX. You can see here that after the index DEX, and this didn't come out that well, but 33% of eyes were not pretreated prior to 12 months. 23% of eyes started other therapy, and about 75% of these eyes remained on DEX monotherapy. So in U.S. clinical practice, DME patients are typically treated with DEX slightly more frequently than the phase 3 clinical trials. When I use Ozurdex every 4 to 5 months, it tends to be the typical retreatment need in patients with diabetic macular edema. For eyes with more than one implant, the median duration between implants was 4 to 5 months. The median number of DEX injections in the indexed eye in the first 12 months of follow-up was 1. The mean was 1.8. A minority of eyes were treated with DEX as monotherapy, receiving no other therapies. Use of other therapies decreased, specifically the anti-VEGF use, after the dexamethasone was given in this real-world analysis. And so thank you again for spending an evening with us, or a short evening, and text your questions here. Thank you, Michael.